Good evening, everyone. So last week we discussed Morphea part 2. We discussed the pathophysiology of Morphea, and we discussed what happens in the background of the disease, how it progresses from an inflammatory phase to an eventual sclerotic or an atrophic phase. This week we'll discuss about the clinical features of Morphea and all its related variants like linear Morphea or a Pansclerotic Morphea or guttate Morphea. So we'll discuss about all of these variants in this video lecture. Now it is very important to understand at what stage you are looking at your patient, whether the lesion is in its inflammatory phase or the sclerotic or atrophic phase or its fibrotic phase, because that helps you to decide what treatment modality needs to be used. Okay, so we need to keep in mind what is happening in the background when we know about the physiology and how to interpret it in our OPDs when we clinically see the patient. Okay, so we'll discuss these aspects in this week's video lecture. And without much further ado, let's start the second part of Morphea series, Morphea Part 2, Clinical Features. Let's begin. Now, previously we have learned that Morphea is an autoinflammatory fibrosing disease. So that is the definition of Morphea. It progresses from different stages. It starts first with an inflammatory phase, then goes to fibrosis where there is increased fibrocytic activity. Then it goes to sclerotic phase where it's more of a thickened collagen bundle and sclerosis. And then the lesion or the dermis becomes largely atrophic and the lesion becomes clinically depressed. So there is atrophy of the epidermis, dermis, and the subcutaneous tissue, which in severe forms can also affect deeper tissues like fascia, muscles, and in fact even bone. Now, the clinical phase dictates treatment modality. If it's in the inflammatory phase or the largely inflammatory phase, the treatment remains immunosuppression and immunomodulation using different kind of steroids or non-steroidal drugs. Okay, if it has gone towards the sclerotic phase or the atrophic phase, you have to correct the tissue defects. Now, here the inflammatory or the anti-inflammatory modalities will not help. You need to physically correct the defects, and you have to use surgical modalities of correction. For example, fat transfers or fillers. Okay, so we need to keep that in mind that if we are looking at a lesion of Morphea, which clinical phase it belongs to. Let's move forward. Now, clinically, there are multiple types of morphea, and there is a it's very difficult to classify morphea into various subtypes because there is a considerable overlap, and there are different definitions used by different authors. So you will find many different kind of descriptive terms for morphea, but largely it can be divided into 5 parts. The first subtype is the Plaque morphea, which is the most common form. The second is linear morphea in a line. Then generalized morphea, which is more than two anatomical units of the body. Deep morphea involving deeper tissues, and mixed morphea in which there are multiple or more than one different patterns of morphea coming together. Okay. Now, we have told you last week that localized morphea is most common in the pediatric age group. Now, there are some others who will say that localized morphea is the major subtype or the most common subtype, but in majority of the articles, plaque morphea has been taken as the most common type of or most common subtype of morphea. It is also known as circumscribed plaque morphea. Okay, so circumscribed plaque morphea is another name for plaque morphea. Clear? Let's move forward. So largely, whenever you are looking at a patient of morphea, or even in a theoretical question, if you're looking at the classification of morphea, that is how you're supposed to, describe it. It is limited if it's involving a certain small segment of the body or a small unit of the body surface area. A little exception would be guttate morphea, in which the lesions are small but they can be widespread. You still term it as one of the types of limited morphea. The second is generalized morphea, in which there's multiple areas of the body, different areas of the body that are involved. Then you have the linear morphea, in which the morphea plaque extends in a line, like a line, okay? Then you have deep morphea, where the depth of involvement is significant. You have the involvement of the subcutaneous tissue and the deeper tissues. And then you have mixed morphea, where you can have more than one forms of morphea occurring together in a lesion or in a patient. So largely you have to look at the 5 different subtypes: limited, generalized, linear, deep, and mixed. That is how you divide it. Okay, let's move forward. So first we'll understand the general features of a morphea plaque, and we will be taking the example of plaque morphea as a prototype since it's the most common subtype. Okay. Now, it has insidious onset, that means gradually progressive, very slowly. It is difficult to perceive what is the exact day or date where the plaque has started to appear. It usually, when the patient observes it, it's already in a significantly atrophic segment. Okay. It starts first with change in texture or color and can appear like a bruise, like some kind of trauma has happened to that site of skin. When the inflammatory activity is significant, you can have symptoms like itch, pain, burning sensation, numbness, and even a little bit of redness on the area. If it involves deeper tissue involvement or it crosses the joint, this can lead to significant morbidities and complications in the form of reduced mobility or contractures, even in limb girth discrepancies or length discrepancies. In other words, if the deeper tissues are involved, you can have difficulties or you can have discrepancies or alterations in the size of the limb. One limb could be shorter or one limb could be thinner because of that. And when we will learn about the linear variants of morphea, we'll see the clinical pictures and we'll be able to understand what we mean by that. If it see, morphea is because of significant inflammation leading to atrophy of structures of the dermis, mainly involving the deeper areas like subcutaneous and fascia also. So all the appendages which are there in the dermis, for example, if hair follicles are involved, you have alopecia of the hairy areas. For example, in Enku, the Sabre form of morphea, you have the alopecia of over the scalp. There is also decreased or absent sweating because of involvement of the sweat glands. In the generalized subtype, when a lot of areas being involved, you have fatigue, myalgia, joint pains, and respiratory difficulties because if it is involving the thorax, if it is involving the chest, it is difficult to move the chest for breathing. So it restricts the movement, and because of that, the pansclerotic variant or the generalized variant can have an additional complication of respiratory difficulties. Now, lastly, morphea plaque is a central sclerotic area surrounded by an erythematous or violaceous margin. So you have a sclerotic area centrally, and around that you have a margin of erythema. And this erythematous margin at initial stages can look like red, but as time progresses, it becomes a bit violaceous or dusky red or a lilac color, and this is known as the lilac ring. The presence of lilac rings when the patient comes to you symbolizes that the inflammatory activity is still going on. So when the lilac ring disappears, the inflammation has now subsided and now the sclerosis has set in. Okay. So if lilac ring is present in the lesion, that means inflammatory activity is still there. The lesion will benefit from using anti-inflammatory treatment modalities. However, in patients of dark skin color like us, like in India, you may have very much difficult. It will be very much difficult for you to perceive this lilac color ring. This description is mostly in the Caucasian white skin individuals. So in dark skin individuals, you might have difficulty in examining and noting this lilac color. So, but you have to keep in mind about the other markers of inflammation like increased temperature on touch or slight edema of the surrounding areas. So keep that clinical pointers in mind. Let's move forward. So with that background information, we'll start to discuss each and individual clinical subtypes of morphea very quickly. Okay. The circumscribed plaque morphea or just plaque morphea is the most common form. Roughly about 50 to 55% of the cases have plaque morphea. It consists of insidious onset of slightly elevated erythematous or violaceous depending on inflammatory activity. Okay, slightly edematous plaque, swollen plaque with centrifugal expansion. That means it goes from center to periphery. That is centrifugal expansion. It can be single or multiple round to oval lesions, size more than 1 centimeter mostly. The most common site involved are the trunk. So you usually see it on the flanks or on the central part of the trunk and over the breast area, but it spares the nipple areola complex. The second most are the face and neck, about 12 to 13%. So we'll discuss the histopathology of morphea here because that is the most important clinical type that we see. So we'll discuss the textbook histopathology of morphea while discussing the circumscribed plaque variant. The epidermis is thinned out and atrophic in the later stage, in the atrophic stage. In the inflammatory stage, it can show some kind of inflammatory damage in the form of basal vacuolar damages or some mild spongosis. but that is a very rare event. Usually the epidermis goes towards the atrophic stage quite quickly because it's not that thick. The major activity lies in the dermis. Okay, so dermis is where you have to look at all the pathological findings. In the dermis, you have the collagen bundles as highly eosinophilic and swollen. So normally, if you have a collagen bundle in the dermis, they will become edematous and highly eosinophilic. Okay, so the color would be orange. So this will be highly eosinophilic collagen bundles, and this is because of increased collagenesis, increased formation of collagen, and also decreased destruction of collagen. A detailed pathophysiology has already been discussed last week, so you can go back and see the pathophysiology where we mentioned that the collagen bundle starts to become thicker. The collagen bundles are oriented parallel to the skin. So usually we have an haphazard placement of collagen bundles, but as it goes more into sclerosis, they are arranged horizontally. Regarding the infiltrate, there is a dense perivascular lymphocytic plasma cells, macrophages, eosinophilic infiltrate. So the most important cells that you need to remember are lymphocytes, which carry the inflammatory and immune activities, and plasma cells, which is because they are the ones secreting autoantibodies. So these two are the major cell types present in the dermis. In the vascular changes, you will see endothelial swelling and intimal thickening, and we have discussed in the pathophysiology video how important endothelial findings are. And pulled up appendages due to fibrosis. So as it goes from inflammation to the fibrotic stage, because it is getting contracted, the dermis is shrinking. So the appendages which are in the lower dermis, like the bulb of hair follicles or the sweat glands which are in the lower part of the dermis, they are pulled up because of the retraction of fibrosis. Okay, let's move forward. As the lesion enters sclerosis, the collagen bundles get homogenized. They are uniformly in color with very few recognizable fibroblasts. The appendages are eventually lost. So that is why you have alopecia and decrease or absent swelling when the appendages are lost. Okay, let's move forward. So look at this biopsy of morphea, and there are certain terms that have been used in biopsy of morphea, like it is also known as cookie cutter section. So when you're baking cookies, you have a cylinder, a metal cylinder, in which you put that cylinder on the dough, and then you cut out this circular, pieces of dough which you bake and form cookies. So the biopsy looks like somebody has used a cookie cutter into the skin. Okay, because it has so well defined edges. However, in this you don't see, but usually the edges are like this in morphea. Okay, so this is the epidermis, dermis, and subcutaneous. So it looks like a proper punched out lesion. So that is why it is known as a cookie cutter section. Since it looks like a box, so it is a box cut biopsy. It has straight edges. There is perivascular lymphocytic infiltrate, which you can see here. Very thick, homogeneous eosinophilic collagen bundles are there in the entire of the dermis. In fact, they are very well appreciated in the lower part. They are slit-like vessels because the collagen bundles are getting swollen up, so they're compressing the blood vessels in between them, and that is causing the slit-like vessels, which you also see in scars. But in scars, they are more of a like vertically oriented slit-like vessels. But here, because of the horizontal orientation of collagen bundles, you see more of a horizontally compressed slit-like vessels. In fact, in between the collagen bundles, you can have some form of infiltrate, a little bit of infiltrate. That is also known as the Indian filing pattern, but this term is not usually, exclusive to morphea. So you don't see Indian filing pattern used in terms of morphea, but that has also been described. There are pulled up appendages where the deeper parts of the, let's say, hair bulbs or the sweat glands are pulled up, and they lie a bit up because of sclerosis of the surrounding dermis. Clear? Hi. Hope you're enjoying this video. I know it's a long video, so I thought I'll give a certain break after listening to such a long videos that I make. If you think that these videos are helpful in your residency, do consider becoming a member. You can opt for Sapphire membership or Ruby membership. I would prefer it to be a Sapphire membership, of course. Um, you get access to longer videos, bonus contents, extra information to make things more interesting, and to cover each and every aspect of the topic that we are discussing. Okay, so I think that's enough of a break.
I should continue with the video, and you should listen to the other person at the bottom right corner tell you different topics of dermatology, venereology, and nephrology. That being further said, let's continue with the video.
So we have discussed the plaque morphea, which is the most common variant of morphea, and now we will discuss each and every variant of morphea very quickly. Okay, I'm not going line by line with generalized or linear morphea. I've just discussed the five subtypes at the start of this video. Now each and every variant we'll discuss very quickly. Okay, now let's start first with deep morphea or morphea profunda. As the name suggests, in deep morphea, the inflammation and sclerosis are there in the deep dermis, panniculus, subcutaneous fascia, and muscle. So the deeper tissues are involved. They can be seen in as much as 50% of patients, and the overlying tissue or the overlying skin shows a puckered appearance, also known as cobblestoning or pure de orange appearance. Okay, so it's more like that the dermis has shrunken, pulling the skin attachments, and it looks more like a peel of orange appearance. That's what pure de orange is. It is felt as a deep nodularity with bound down nature of the lesion. There is significant asymmetry and functional impairment because deeper tissues are being involved, fascia, muscles can be involved, bone can be involved, and because of that, there is significant comorbidities. Complications like calcinosis cutis have been described with deep morphea. So slowly, there is loss of upper tissues, gradually extending deeper to involve the subcutis and deeper tissues. In fact, in biopsy also, you will see more sclerosis at the deeper levels involving the deep dermis and the subcutis, extending to the underlying fascia, but we usually don't see fascias and muscles in a biopsy. Okay, if we see that, the involvement extends to there also. The next variant is Atrophoderma of Pasini and Pierini. It is also known as, or if you want, it's a good idea to remember Atrophoderma of Pasini and Pierini as a somewhat superficial and atrophic variant of morphea. So here, the deformity or the depression is more superficial. You don't see the deeper involvement or the pandermal involvement that you see in morphea. It's also a rare variant, symmetrically distributed over the trunk is as the most common site of involvement, and it is the lesions are mostly non-indurated. That is why it is more atrophic. So it's a superficial involving the upper tissues, atrophic variant of morphea. The color is about blue-gray to brown, hyperpigmented, sharply demarcated, depressed patches with a cliff drop edge. And that is a very important finding, the cliff drop edge. So it looks like this, like a cliff. Okay, so this is the cliff drop edge. Clear. So there is sudden drop at the periphery of the lesion, and you see the depression or the loss of tissues more superficial as compared to other forms of morphea, and that is what you see in Atrophoderma, Pasini, and Pierini. Some authors consider this as a separate entity associated with morphea, not as a variant of morphea. In fact, some other authors regard it as very superficial variant of plaque morphea. Okay, so if the plaque morphea involves deeper tissues, then deep morphea, superficial tissues, then Atrophoderma, Pasini, and Pierini. Okay. The next variant is generalized morphea, also known as disseminated plaque morphea, because it involves larger area of the body and multiple areas of the body. A good definition to remember is that more than four or more than four individual plaques, more than 3 centimeter in size, confluent involving more than two anatomical sites. So anatomical sites like head and neck, right upper extremity, left upper extremity, right lower extremity, left lower extremity, anterior tongue, posterior tongue, and head and neck. So these are 7 anatomical sites. Out of these 7 anatomical sites, if more than 2 are involved with multiple plaques more than 4, size more than 3 centimeter, then this definition can be used to have a diagnosis of generalized morphea. But in OPD and clinics, we can easily look at the patient and label it as generalized morphea. It's about 7 to 19% in children and about 13 to 52% in adults. Now, the important factor to remember about generalized morphea is that it is associated with a lot of extracutaneous features. So, all the features like myalgia, arthralgia, fatigue, all of these generalized involvement, the B symptoms or the extra, inflammatory symptoms like myalgia, arthralgia, fever, fatigue, malaise, all of these is more associated to generalized morphea. There's also a higher chance of familial autoimmune disease, and also a higher chance of developing extragenital lichen sclerosis. So these 2 points make it a bit important to label a person as generalized morphea, so that you can keep an eye out on this kind of extracutaneous manifestations. Okay, let's move forward. So let's discuss Pansclerotic Morphea. This is the most significant variant of generalized morphea. So we'll discuss that into in a bit much detail. So it's a rare variant, but more common in the pediatric onset cases of morphea. It is described as extensive, often circumferential involvement of majority of body surface area. When we say circumferential, it means it surrounds the body. So circumferential involvement of the majority of body surface area and spares fingers and toes. Now fingers and toes are mostly involved in the systemic sclerosis aspect of disease. So this is one point where you can differentiate pansclerotic variant from systemic sclerosis. In SS, fingers and toes are involved. You have sclerodactyly, but in morphea, the pansclerotic variant, the fingers and toes are spared. There is widespread, severe progressive disease with deep fibrosis and rapid progression to involve deeper tissues like muscle, fascia, and bone. So the level of inflammatory damage is high. That is why you have more extracutaneous manifestations, more malaise, more arthralgias, and there's a rapid progression of disease and rapid onset of fibrosis in pansclerotic morphea. Okay. Remember the name. Pan means widespread and sclerotic means a lot of sclerosis is happening over the whole body. So that is what we mean by pansclerotic morphea. Okay, so in the previous slides we have discussed the generalized form of morphea, the localized circumscribed plaque form of morphea, and these are the major subtypes that you see. Now the other clinical aspect of morphea, or the other clinical major subtype of morphea, is the linear morphea. So let's discuss the linear involvement or the Blaschkoid involvement of morphea. So in linear morphea, about 10 to 20% of the cases are seen in adults, but in children in pediatric onset age group or the pediatric age group, it rises rapidly to 42 to 67%. And that is why we told you previously before that the linear variant is more common in the pediatric age group. More common in the pediatric age group. In that, the limb and trunk variant, in which involves the trunk and the limb, is more as compared to the head variant, in which the head is involved. The lesion follows Blaschko lines. Okay, I'm not explaining what Blaschko lines are, but it follows the Blaschko line. Okay, let's move forward. Now, now the next variant in the linear form of morphea is linear atrophoderma of Moulin. So in linear atrophoderma of Moulin, it's unilateral, depressed, hyperpigmented Blaschkoid lesions. So this is Blaschkoid lesions on the trunk and limb. Okay, a good way to remember is that it looks exactly like Atrophoderma of Pasini and Pierini, but in Atrophoderma of Pasini and Pierini, it was on the trunks, while the Moulin variant is a linear Blaschkoid distributed lesion. So it is distributed along the lines of Blaschko. The years of onset is about 6 to 20 years. Biopsy shows hyperpigmentation with normal dermis and collagen. So remember, in Atrophoderma of Pasini and Pierini, it was more of a superficial variant of plaque morphea, while linear Atrophoderma of Moulin is a linear variant which looks like Atrophoderma of Pasini and Pierini, but in a linear Blaschkoid distribution. There is significant atrophy of subcutaneous structures and which can be easily confirmed by a skin ultrasound. Some authors label it as linear Blaschkoid form of Atrophoderma of Pasini and Pierini. So you can easily remember that Atrophoderma of Pasini and Pierini is like a superficial variant of plaque morphea, while linear Atrophoderma of Moulin is a linear Blaschkoid form of Atrophoderma of Pasini and Pierini. I know it can get confusing with all sorts of names, but don't worry, slow it down, listen to it, and you can easily remember these variants of morphea. Now in mixed morphea, more than one subtype of morphea present. So you can have linear morphea with plaque morphea, linear morphea and pansclerotic morphea. So more than one variant can be there. Deep morphea with plaque morphea. So you can have more than one subtype of morphea together. Most common variant the most common combination seen is the linear limb and trunk variant of morphea with plaque morphea. So this is the most common combination, but any combination of any two types of morphea is labeled as mixed morphea. So it can be seen in about 2 to 3% of adult morphea, but higher in the pediatric age group. So this is also one morphea which is more common in pediatric age group. The first being the linear morphea and the next is mixed morphea. Most common extracutaneous manifestation has been arthralgia, seen in about one-fourth of patients, followed by dysphagia, dyspnea, even Raynaud's phenomenon in some cases can be seen. Now, Raynaud's phenomenon is more commonly seen as a feature in systemic sclerosis, but in the extracutaneous manifestation of morphea, you can have in about 8% of the cases. Most of the extracutaneous manifestations are there either seen in the linear morphea or in the deeper involvement, mostly seen in the pansclerotic morphea or deeper involvement in the linear subtype. So in the linear subtype, neurological involvement can be seen in as high as 31%, ophthalmologic 8%, joint contractures 31% of children or 15% of adults, especially if it crosses the area of movement or joints. Neurological manifestations include headaches, seizures, migraines, cranial nerve palsies, spasms, peripheral neuropathy, neuropsychiatric problems, CNS vasculitis. You can even have associated psychosis, but that is not, not necessarily neurological, more of a psychiatric manifestation or psychiatric extracutaneous manifestation. If it involves the eye, remember the most common variant in adults is the head and neck variant and it involves the eye. So the features that can be seen is episcleritis, anterior uveitis, keratitis, glaucoma, xerophthalmia, strabismus, mydriasis, papilloedema of the optic disc. So all of these features can be seen as extracutaneous manifestations. Along with that, you can have loss of skin, loss of fascia, loss of tissue, deeper tissues, loss of bone, physical deformity, psychosocial comorbidities, everything can be clubbed together in extracutaneous manifestations. Let's move forward. So regarding differential diagnosis, I will not go into detail, but it depends on what phase of morphea you're looking at. In the inflammatory phase, it can differentials include granuloma annulare, extragenital LS in the early phases, Lyme disease because it has that kind of lilac ring around, MF, cutaneous mastocytosis, radiation dermatitis is very important. You need to rule out. We have discussed radiation-induced morphea in the pathophysiology of morphea video, FDE. In the pansclerotic variant, you can have the diffuse form of systemic sclerosis, scleroderma, GVHD, sclerodema, scleromyxedema, PCTs. Okay, all this drug-induced morphea, carcinoid syndrome, nephrogenic systemic fibrosis, all of these are the differentials. You can look at the list in Rooks 10th edition, page 55.27. Okay, in the phases of hyperpigmentation, for example, in the hyperpigmented phase, you can have actinic LP or cafe au lait macules. In atrophic phase, lipodystrophy, steroid-induced lipodystrophy, acrodermatitis chronica atrophicans, which is the late-stage Lyme disease, which implicates or connects Borrelia with Morphea pathology. So that can also be taken as differential diagnosis. Lipodystrophy because of HIV infection is taken as a differential of perirhombus. If it's but in lipodystrophy because of retroviral infection, it is mostly symmetrical bilaterally, while perirhombus is unilateral. Linear morphea, the differentials include linear panniculitis, linear LP, linear LE, linear LS, lipodystrophy, if it involves a linear part, focal dermal hypoplasia or the Gold syndrome, so that is also one of the areas of dermal hypertrophy, and steroid-induced atrophy if it happens in a localized area or along the course of veins. Okay, let's move forward. The investigations are not that much required because the diagnosis is largely clinical. You can do a hematological examination, which is usually normal, but you can do it for autoantibodies. So look at ANA and RF factor. If you have RF factor positivity, that means you have more chances of joint involvement, arthralgias, arthritis. If you have ANA positivity, you have more chances of other autoimmune disorders or a protracted course or difficult response to treatment. So these kind of features are associated with if you have autoantibodies as positive. You can have raised immunoglobulins. ESR is a marker of active disease. You have more ESR, you have more high sensitive CRP. So these are all markers of active disease because these are markers of active inflammation. Creatine kinase, aldolase can be seen as markers of new lesions, muscle atrophy, and limb shortening because of there's increased inflammatory activity and tissue destruction going on. Borrelia serology only if it is suspected. We have told you that in the pathophysiology video that the connection is not that robust. So only do it if you suspect Borrelia to be one of the causes. For associated autoimmune disorder investigation, for example, thyroid evaluation because autoimmune thyroiditis is a significant association. You do it if you want to do any kind of blood investigation specifically. But if clinical symptoms are present or suspicion is present, not in every patient. The most important investigation is skin biopsy, mostly at the inflammatory edge. So you can look at the level of inflammation. If the disease is stopped, you may look at the sclerosis to look at the depth of involvement. I will not go into details of skin biopsy because we have discussed histopathology while discussing plaque morphea. Important as investigations include photographic evaluation. You need to click a photograph. You can do imaging studies if the area that you practice allows, or it is not difficult to get imaging of morphea done. If you can, if it looks viable, then get MRI and CT scan, especially if head and neck area is involved. Okay, MRI shows you the depth and extent of deeper tissue involvement, the horizontal spread as well as the vertical spread. You do a contrast enhanced brain and head and neck MRI to look in case of facial lesions, so you can know at what depth the area is involved, especially in children, because that becomes the investigation of choice. Okay, in children with head and neck area involvement, especially in case of linear morphea. MRI can also help to reconstruct 3D models and look at exactly what is the extent of involvement or the extent of soft tissue loss. In fact, the recommendation or a suggestion in Rooks is that you have to do it at 1 or 2 yearly intervals, but it is only a suggestion. I don't think so it's part of any guidelines as of now, but it's better to have a baseline evaluation by using an imaging modality in case of head and neck involvement like linear morphea or any morphea over the head and neck region to look at the deeper organ involvement. CT scan can also help in 3D reconstruction, and they're better if bony loss are there. A CT scan is nothing but a very glorified X-ray. So in X-ray you see bone properly, you bone better. So for better visualization of bony abnormalities, CT becomes better. It's easier, it's quicker. While MRI is more of a soft tissue, it will tell you about soft tissue loss more clearly as compared to CT. Other modality which can be used are skin USG, which are operator dependent. Dopplers, thermographies, durometer. Now, durometer is a way to find out the induration of a skin lesion. You can use it. I don't think so anybody has used it. I have not used it any time. So that is just for academic, completion of list. You may use a durometer too. Let's move forward. With that, I finished the lectures. I've covered all the three larger textbooks of dermatology. Other textbooks I've also covered, not much. That's why I'm not mentioning it here. These are the reading recommendations. And if you find these videos helpful, do consider becoming a member of the channel. Remember, I'm trying to phase out Ruby members in the coming few months. And if you think that these videos are helpful in your residency, do consider becoming a Sapphire member of the channel. It helps me to, it motivates me to create these videos week after week. With that, I shall finish this video. I'm trying to finish it before the entire hour gets, used up. So I'll finish it here. I shall see you next week with further topics. Till then, adios and bye bye.